Today we'll have a couple topics, alkylators, platinating agents, and then antimetabolites. And then just a couple tips on research and pharmacogenomics and oncology genomics. All right. So we'll talk about mechanisms of action, adverse effects, supportive care strategies, and then a couple tips on investigational drug and oncology genomics. These agents are a very broad approach. They're not targeted, so they have a lot of off-target effects. So the talk today will be a little bit more about talking about adverse effects on a systems level basis, and really important to recognize, I guess, the kind of the rare serious adverse effect versus the common still like problematic to the patient adverse effect and how to manage it. So those are kind of the two themes of the adverse effect talk. We'll start with alkylating and platinating agents. So this, like the history of this goes back to World War II when they were studying gases for the war, mustard gases. And at Yale, they had found that methchlorothamine was a little bit more stable than sulfur mustard. And studies on animals found that lymph tissue shrunk dramatically. And so this was well known in the early 40s, but not published until 1946 after the war. And this kind of formed the basis for all alkylating agents going forward. There are 7 different subtypes of these drugs, and it's a real kind of ingenuity, a lot of different mechanisms. So starting with the mustard gases, moving towards a rational drug design around a cation that was really good at letting go of electrons. Random screenings at the NCI, so they screened thousands of chemicals for anti-leukemia activity, and some of them turned out to have that. Thiazines were initially developed as antimetabolites. The methylhydrines were actually used first in psychiatry, and they turned out to be cytotoxic. And then the Lawrence Livermore lab found the platinating agents, the same lab as the not the same lab, but the same facility as the Oppenheimer and nuclear research. So 15 drugs today, and in the alkylating agents. And I guess I'd like to just kind of point out that these drugs are still widely used. Sorry, I'm trying to. These drugs are still widely used, even though their use has gone down somewhat. They're still part of many curative cancer approaches. Almost 19,000 doses were given over last fiscal year, and then close to 2,000 patients. We're in 345 treatment plans. A lot of those are kind of similar plans, but there are a lot of unique plans. And then discovery from finally in the 50s all the way to 2008 with bendamustine, which was initially discovered in Germany. And so a lot of groups are represented here, especially with the drugs that are used a lot. So drugs with more than 700 doses, we have bendamustine, cyclophosphamide, ifosfamide, and all the platinating agents. And then drugs, there's 5 drugs with over 100 patients per year. And just in general, 30,000 patients are seen at the cancer center a year, but really only about 10,000 are actively treated with chemotherapy. So this is still roughly 20% of patients are treated with these drugs. And again, there's 7 classes. So this is generally how they work. So compounds that are capable of covalently binding a group, alkyl group under physiological conditions. The platinating agents just they have a platinum group instead of the alkyl group. And so the DNA-rich nucleotide will attack the azernium component and form this stable covalent bond. There's many ways that these drugs can work. So with alkylated guanine and cytosine. It's not as stable as guanine and thymine, and so, or sorry, that's um, guanine and thymine, of course, are not the correct DNA, and the enzymes will come through and deplete the DNA because that it sees it as an errant molecule. But because of three bonds, it's formed more naturally. There'll be direct fragmentation of DNA and RNA, and then cross-linking. So you can have intrastrand, and strand to protein cross-linking. So all with covalent bonds, and this is how the DNA is interfered with. So in talking about the uh, like package insert warnings and precautions, really is all systems are affected by these drugs. And so on these tables, if it's a black box, it actually is a black box warning. If it's a blue X, that's just the platinum drugs. So you can kind of see a class effect with some of those agents. For instance, for ocular toxicity, ototoxicity, and neuropathy. And then on the far right side, if it's 4 to 10 drugs involved with a first effect, they're lit up in yellow. So seizures are problematic. So for some of these drugs, we'll give Keppra or levetiracetam prophylaxis. Neuropathy is commonly involved in the platinum agent drugs. Pulmonary toxicity, pulmonary fibrosis is um, a heavy warning. Rare toxicity, but it is there. Busulfan was the first known drug to be a direct pulmonary toxin. Cardiotoxicity, there's a real diversity of cardiotoxicities that we'll talk about a little bit. Hepatotoxicity, one of the more common. And then GI toxicity. So these drugs, many of them have very high emetic potential. Moving on to the bottom half of the systems review. So nephrotoxicity, infection, extravasation, and then need for experienced provider are all within that 4 to 10 range. Experienced provider essentially means like you have a system organized, like you might have clinical practice guidelines for how to manage the supportive care. You'll have nursing training, pharmacy training. You'll have site of care requirements. And so a lot of those drugs have a lot of operational needs. And finally, the real kind of widely uh, the wide incidence adverse effects are myelosuppression, secondary cancers, and hypersensitivity. And so almost every drug has this. And myelosuppression, you can see most of the drugs are black box warning. Secondary cancer, there are 4 drugs that are black box warning. All right, so this table shows why cyclophosphamide is our most commonly used alkylating agent. It just has such a clean onset, nadir, and recovery period. So you can stick to that every 3-week dosing for your breast cancer regimens or your lymphoma regimens, and it's really predictable. Um, Other drugs like melphalan and bendamustine and carmustine, the longer nadirs are perfect for a bone marrow transplant setting or a CAR T lymphodepleting setting. So we're using those drugs to really clear out the space, also deplete immune cells, deplete lymphocytes, and then be anti-cancer as well to allow the new cells to grow. But you can really see with cyclophosphamide why we prefer that drug. Febrile neutropenia, here's like an NCCN list, and in yellow, the alkylating agents, and green, the platinum, and almost every, not everyone, but the majority of these regimens in the high risk febrile neutropenia are these agents. So infection as a warning or black box warning is very appropriate. Just a couple tips on growth factor treatment. So patients often come to the ER or through the cancer center. They can be directly admitted to B66. Essentially, like you want to make sure if they're on a short-acting growth factor daily to resume that. But if they had Neulasta or Fafilla in clinic, then we would not add the short-acting drug on top of it. And then if no prophylaxis, generally that only happens if they're like an intermediate risk neutropenic fever regimen. A lot of those regimens still include alkylating agents. You'd want to look at the risk factors, so greater than 65, sepsis, ANC less than 100 are like expected to be longer than 10 days. Pneumonia, invasive fungal infection, hospitalization at the time of fever, and if they've had past episodes of febrile neutropenia. And so if these risk factors, if any of them are present, we usually start growth factor. There is a guideline on neutropenic fever. This is good at teasing out those people in the ER that may not need to be admitted to the hospital. We use MASIC scores to determine that. There's more information in the guideline, and then there is an order set for ordering the appropriate antibiotics and et cetera. All right, moving on to emetic potential. So here you can see all but one of the high emetic potential drugs is a alkylating agent or a platinating agent. Most of the 16 to 90% high moderate drugs are also this. And so SYNV prevention and treatment is very important. Every 3 years, we update our treatment plans to incorporate the most recent guidelines for SYNV treatment and prophylaxis. Here's an example of a GU regimen with cisplatin in it. And these treatment plans have been really, really helpful to have a uniform and consistent approach across the health system. All of these guidelines are reviewed. So ASCO, NCCN, and ESMO all have excellent guidelines. And then we have a health facts for you. I just want to kind of point out the ways to manage nausea in the health facts for you. A lot of these tricks we start with first before some sort of pharmacological approach. And a lot of these really, really do help. So smaller meals, 5 to 6 times a day instead of 3 meals. Ginger chews. Don't lie down after you eat. Relaxation meditation apps. The dietitians at the Carbon Cancer Center. We really like to start with that approach. If there are really good patient information tools as well, if you're having somebody that's wants to dig deeper, ASCO has really good patient handouts. So medication or pharmacy-based tips for managing. So some medicines we are okay on an empty stomach and actually preferred. So temozolomide is a good example in this class. And in the treatment plan, we'll build it to be given at night. We'll actually have half a dose of endanzatron given before each dose to help with nausea. And then extending the antiemetic premedication. Obviously, we don't go there right away, but if somebody needs to go from olanzapine 4 days to maybe 10 days, or if they need to do ondansetron an extra 3 days, most patients kind of know their bodies and know what works for them. You just really work with them on which medication they feel is helping the most. Adequate hydration, so either increase the pre-dose hydration or a couple days later have them come into the infusion center or the clinic to get another liter of fluids. We commonly do that with high-dose cisplatin regimens, so ones for sarcoma or even some GU regimens. We'll have people come back. So the next cycle, we can go from a moderate risk antiemetic regimen up to a high risk. So we can add a aprepitant, we can add olanzapine, and then occasionally, we don't do this very often, but we'll consider changing chemo into divided doses. Usually nowadays there's you can go to switch to some other component where that's not as common, but we still can occasionally think about that. Like Doxil comes to mind for like breast cancer, an 8th or 9th regimen. And then every 3 years we're updating the beacon builds to support uniform best practice. So we really try to build a consistent platform. Okay, moving to neurotoxicity. Um, Ifosfamide was like this is one of those adverse effects that is more serious in nature but less common. Um, but it results from accumulation of chloraldehyde due to like the NAD, like NADH to NAD is limited, so there's less dehydrogenation of the metabolite. Um, it's less than 10% of patients. It also does occur with procarbazine and thiotepa. Usually they're going to be inpatient for this, but not always. And it tends to be very, very obvious that this is going on. This is not like a gray area usually. So initially there's like less arousability, disorientation, but then full on visual hallucinations, mental status changes where, the patient may be a well-known, um, like very verbose and smooth talker, and then turn into somebody that's angry and yelling and throwing things in the room. Paranoia, loss of orientation. So it's usually very, very obvious. Onset, 2 hours to greater than 20 days. Usually it's less than 48 hours. Um, and then like once the drug is stopped and once we treat it, it usually gets better within 48 to 72 hours. I've definitely seen out a little bit further than 72 hours, but usually by 2 days, you're feeling pretty good. Almost every case we've had has risk factors. So like they might have liver dysfunction, renal dysfunction, the albumin might be 1.8, 1.9. They had like CNS disease, and like are a high tumor burden. So almost always these risk factors are known, and we actually built these risk factors into the treatment plans just so people can take a time out and assess, is this the right patient to treat with this medication? Um, so essentially, we treat this with methylene blue. It restores the path. It does like two things. It restores the pathway and then prevents formation. So of the toxic metabolite, the treatment dose is 50 milligrams IV every 4 hours, and then we'll do secondary prophylaxis for the next cycle, and it is pretty good. But a lot of times, those high risk factors are better by the next cycle. So you're treating somebody that's really in the weeds cancer wise, and you can get the tumor under control. You can improve liver function, get a better appetite, so the albumin's better. And so, if that's the case, you don't really need secondary prophylaxis if all the risk factors have resolved. Um, and when patients go to the bathroom, this is what it looks like. So it's very blue color. Um, Moving on to our next neuropathy. So these drugs, the platinating agents, are so common. So several hundred patients a year. And so we'll hear about this adverse effect more because so many people are treated. There's both acute peripheral neuropathy and persistent peripheral neuropathy. Acute oxaliplatin is the highest incidence. It also happens with both carbo and cis. Reversible, resolves in 14 days. Usually it's the same day of the drug that the patients will experience the symptoms. And then it can be a dose limiting toxicity for sure. If people can't get out of their car, they can't open doors, can't do activities of daily living because of this, it can be a dose limiting toxicity. And persistent lasts more than 14 days. So generally, like the biggest part of that is the paresthesia, dysesthesia, and hypothesia. And this is not like a lot of people just think it's fingers and toes, but it's really other areas as well: Achilles heels, elbows. So like walking downstairs can be a real balancing act for these patients. And so writing, buttoning, swallowing, difficulty walking can all be affected by these adverse effects. Unfortunately, there's still not great drugs for this. It has been an area of active study, and it continues to be so into the future. A lot of the regimens we're trying to build we're trying to replace platinum drugs, but they're still very effective and are still more effective than alternatives. So I can't stress enough that the one drug that has some benefit, especially with platinums, is duloxetine. And we usually go with 30 milligrams for 1 week and then up to 60 milligrams. And it can be enough to kind of turn the tide for a patient where they're able to button their shirt easier, and hold a fork, etc. So nothing else has been shown to be effective. Dose delayed reduction and stopping we will occasionally do with full fox regimens, some of the pancreatic cancer regimens. But duloxetine is ideally the go-to. You'll see a lot of patients coming from other systems on gabapentin, but it really doesn't have the same data as duloxetine. The ASCO handout for this is actually like 2 full pages. It's a lot of reading. It is a good, um, like good information for the patient to have. Um, as soon as they experience the symptom, they'll understand what all this stuff means. But water heaters, you can't sense the water's hot or not. Like you can slip on, any kind of spill. A lot of patients talk about, oh, they broke 2 dishes. They've never done that before. They broke 2 dishes. So not using fancy stuff or like things that you don't want to break. Yeah, rubber gloves to wash dishes. Like driving, of course, is very, very important. You got to make sure you're safe. Um, yeah, so all sorts of kind of good ideas here, and patients really they do appreciate this information because they recognize it in their experience. Kind of the saddest one I ever had was somebody that she loved knitting, and that was her main hobby that she did hours a day in retirement, and was not able to do so, and decided she did not want to continue the platinum drug because of that. So it does really affect people. All right, a lung toxicity now. This is not common. The really odd thing about this is they're usually going to come back 2, 3 years after you treated them with this toxicity. And then a lot of these symptoms are, relatively vague, and the workup takes a long time. So cough, dyspnea, fever, they might go to their PCP once or twice and it just doesn't go away. And so it's a really, really sad effect when it happens. We do give steroids. It sometimes works, but I would say less than half the time, and people end up in a really, really bad spot. Some We have had people go on to lung transplant with this adverse effect. It's very rare though. I would say maybe 1 every 5 years is what we're seeing nowadays. Cardiovascular, like as I mentioned before, it's just a very diverse. Um, so you can have hypertension, you can have effusions, you can have heart failure. Um, with high dose cyclophosphamide, early on we dosed 90 milligrams per kilogram, and with that dose, this is for bone marrow transplant. 5% of patients ended up with heart failure. So that that was deemed too high, and the dose has been dropped since. But brocarbazine is because of it's an MAOI inhibitor, so avoiding alcohol and cheese. And a lot of these effects will come on during the cycle, so they're not going to be even like the heart failure effects. You'll start noticing within 30 days or so. So these are not effects that take forever to show. We have had heart block, and you just kind of you treat that as you would for the American Heart Association guidelines. Liver toxicity is also rare. So, busulfan is another drug, but cyclophosphamide, the most common agent, it does happen with. We look for this classic triad of weight gain, right upper quadrant pain, and increases in liver labs. And this is with transplant doses as well. So it's within the first 30 days of transplant. You're not going to see this with your breast cancer doses or your lymphoma CHOP doses, for instance. And we use Ursadel as prophylaxis for all patients, and then defibrotide is a treatment for this adverse effect. There's a lot to defibrotide, so make sure you look at the clinical practice guideline if you need to use it. I won't go into details here. Again, this risk factors are associated with the vast majority of these patients. They've often had heavy chemotherapy exposure. They've often had radiation therapy before getting this. It's more common in pediatrics than it is in adults. Renal toxicity, we'll go through a couple different renal toxicities. So this hemorrhagic cystitis is due to acrolein accumulation in the bladder. And so we try to give, chemo earlier in the day for these patients. Doesn't always happen, but you don't want it sitting in the bladder overnight. So tissue edema, ulceration of the mucosa, and then it can invade the smooth muscle fibers. Up to 10% incidence. Any dose of ifosfamide, high dose cyclophosphamide, or chronic oral cyclophosphamide. And then urinary urgency and frequency, burning sensation. This is pretty obvious by the time it presents. Patients know, like, this is totally different than anything they felt before. And usually the onset is relatively quickly. We really, really like to give 12 full hours of hydration after ifosfamide doses. And so that helps prevent this from happening. And then in our treatment plans, we have UA tests every day to check for even low amounts of blood in the urine. Here it is on the CT scan, and the edema and inflammation is obvious in the bladder there. So our best plan is to prevent this. So it really can limit patient selection because you really need 200 an hour of fluids for many hours. So people with heart failure or advanced lung disease might have trouble tolerating this. And then Mesna is used, which covalently binds to acrolein and clears it from the kidneys. And we always have to use Mesna with ifosfamide. The reason for that is there's 5-fold the amount of acrolein metabolite with each ifosfamide molecule than cyclophosphamide. And we give it both IV and oral, so oral dose is double the IV amount. Here's a picture of that. So ifosfamide has several metabolites. Because of that, there's more acrolein produced than with cyclophosphamide. And here's a treatment plan. As I mentioned, the 200 mils an hour of fluids and the UA test. This is all built into all ifosfamide regimens. Yeah, so roughly about 60 patients a year have ifosfamide. And then direct renal toxicity. The platinum agents, cisplatin would be the worst. Both oxaliplatin and carboplatin also have renal injury, but cisplatin is the highest incidence at up to a third of patients. And with the sarcoma doses where you're 100 mg per meter squared, you are seeing that over, definitely seeing 1/3 of patients with renal injury. So it's not super understood. It's just oxidative stress, DNA damage, inflammatory response. We don't know the exact mechanism, but hydration before, during, and following, like I mentioned before, bring them back in for a liter of fluid 2 days later, monitoring the labs closely, replacing labs if you need to, magnesium, bicarb, sometimes even phos we have to replace. And then, yes, we try to push the dose for a lot of these courses because they're curative intent, but occasionally you can't get away with that. You have to dose reduce. Risk factors: renal impairment at baseline, older patients, really try to stop all the nephrotoxic meds like NSAIDs, etc. And then there are patients that assessing hydration status is really important. We'll have people come in from a weekend of partying, and you can just kind of tell, and you got to make sure to get them extra fluid to get rid of the alcohol. Um, this table really just kind of calls out that renal dosing of these agents is not necessarily in the FDA package insert, and that's because requirements in the 50s to the early 80s, when these drugs were mostly developed, was did not necessarily require renal dosing. And so it is in a handful of the drugs. The red medicines it's a package insert warning, and a black medicine is a package insert black box warning. So cisplatin and ifosfamide are black box warning. Cisplatin, we have decent dosing for that, but to be honest, I don't know. People think about switching to carbo if we really have creatinine clearance less than 40. You're going to give up a little bit of efficacy for some types of tumor, not all tumors, but some tumors you're going to give up a little bit of efficacy, but you'll be able to save the kidneys basically. So all of these studies are relatively small. Like, the vast majority of them, I shouldn't say all, but this will be based on 30 patients or less to kind of figure out this dosing. So it's not a robust FDA medication label dose. Hypersensitivity, we mentioned it's over several of these. I think it was 11 have this as a warning. This is generally type 1 hypersensitivity, so IgA mediated release. And carboplatin will have the highest incidence. Um, so essentially, unlike an infusion reaction, you try to treat the symptom with hypersensitivity. The onset can be minutes. We stop the drug, of course, stop it right away, get vitals, and then use the medicines to treat the problems you're seeing. And so definitely, it'll be obvious if it's a very severe symptom. You're obviously going to stay with the patient. There can't be alone to watch evolution of the reverse effect. And then yeah, providers, nurses, the medical team all will have to be involved in this. So we do have a clinical practice guideline, and then the table one is, it's something to really kind of keep handy. It's generally it works very well. Like once in a while, you'll have a symptom show up that's not on here, but these are by far the most common symptoms. And so for hives, you'd want to do Benadryl and famotidine. You wouldn't necessarily need albuterol and Dex for that, like you would for shortness of breath. And so it's hard to I don't have this table memorized. I don't know if the providers do. If you do, you might. But the recommendation is to really treat the specific symptom, and you might have more than one symptom at once, of course. Then there's also order sets with all these medicines in them. Like if you look oncology emergency order set, it'll have all these medicines ready to order. And then we actually have desensitization for carboplatin. Again, we give about 4,000 doses a year, so some of the patients are going to end up with this. I'd say it's about 5 a year that need to be desensitized. So this is actually built into a beacon plan. We actually have a clinical practice guideline for it, and it works pretty well. Most patients, it is more time in the clinic, but not that bad. I'd say about 5 hours to get through this. And if you only have 6 cycles, that's you can do that. Um, but just to be aware that it's out there, and it's much easier to use the order set than do it manually. Okay, a lot of dosage forms. A new one this year is intraarterial melphalan or melanoma with hepatic mets. But yeah, topical, that would be for like a T cell type disease. Carmustine, we have implant wafers for brain cancer. So the wafers are put in the surgery. We don't really use those anymore, but Thiotepa intercavitary, so a pleural effusion. Thiotepa is commonly used for that. And then drug interactions, I don't have these memorized, but kind of note that it's not really a class effect for drug interactions. It's best to look it up um, every time. So like bendamustine, we see this commonly, like either somebody smokes or they're on omeprazole. That's a very common one. Other common one, like yeah, thiotepa and bupropion, we'll see. Thiotepa and sertraline, we'll see. So the message here is, look it up every time. And usually it'll be flagged for us in pharmacy, but we really always appreciate when the providers catch this up front instead of on the back end. All right, so that's the first section. I'm going to move through this a little fast since I'm a little behind, but just want to kind of an announcement for the first year people. The investigational drug service at UW is called the PRC, so Pharmaceutical Research Center. Everyone on a clinical trial will have a yellow research flag. And then in general, all prescribers for the trials have to be registered with FDA. They have to go through training. They have to have some education and sign off. And fellows occasionally are on these studies, but just be very careful if you're not registered for the study to not sign it. APPs as well. There's select trials that APPs are registered in, but you cannot sign it if you're not registered. Most of the builds have the names of the doctors that are on the protocol, but not all of them. So just be really cautious with that. And then the pager 2717 for PR like research related questions is answered from 7 to 10 at night every day. So it's a good resource. So Tempest is kind of our most common NGS platform now. We do still use Foundation One and other reports. I'm sure everyone's seen this, but just so we're all on the same page, like the genomic variants are on the top, both somatic and germline, and then the immunotherapy markers, mutational burden, MSI, IHC. The second page is the medication section, and so I'm just kind of calling this one out. So a lot of the times this will be drugs that are not necessarily FDA approved yet. And so in general, they'll have, here's a prostate cancer patient, PARP inhibitor approved for ovarian cancer, but this exact variant, it's shown to have efficacy in. And so those will usually be tagged with NCCN, FDA, or Memorial Sloan Kettering OncoKB tags. A lot of times, so like insurance might deny this up front, and with pharmacy, we'll help you in such. But it's good to use a couple of resources to get the information you need on the variant to submit to insurance, for example. And then clinical trials, they'll have some variants of unknown significance. And with Tempest, I just really want to stress that these are not. It's pretty obvious, but they're not updated in real time. So like if these are 2 years old, this drug may no longer be in fashion. If it's a year old even, it may no longer be in fashion. So we have to be really careful with that. And the most common resources we use in pharmacy are OncoKB, which has information on the oncology genomics. And then the FDA will have both oncology genomics and pharmacogenomics. And so you won't find stuff on like pharmacogenomics in OncoKB per se. So like TPMT or mercaptopurine will not be there, but it will be in the FDA page. And then if you really have to dig deep on these variants, both ClinVar and CBioPortal are helpful to get extra information for prior authorizations, etc. This is the front page of OncoKB, oncokb.org. They cover 144 drugs, 881 genes, and every year it's growing. Level 1 and 2 are relatively well established. Level 1 will be FDA approved drug. Um, and it's an excellent resource with, once you search those drugs, they'll have references and et cetera. And finally, this FDA table, it now has 273 annotations on about 140 drugs for cancer. And so this table is only package insert recommendations, but it's a very good. So you're not going to see a lot of off-label stuff here, but you will see standard of care stuff and pharmacogenomic drug monitoring toxicity stuff. So it's good to see. Okay. Third section, antimetabolites. I guess if I could ask the audience, is anyone using the Tempus app? It's another thing I'd recommend, and if you don't have access, you can email me, and I can reach out to the coordinator to get you access. But as an APP, for instance, if you work with 4 or 5 doctors and you want to have access to their records, you can have it on the app or their website, and it's really nice because you can search by disease, search by variants, search by germline versus somatic, and it can kind of be a nice way to make sure you're treating your patients appropriately, to be honest, and more of a community health-based level. But is anyone using it? I'm just curious. Okay. Oh, okay. I'll send some information out on on the app. It's also great for research, like quality improvement initiatives.
Is it the same as the
Highly
portal?
recommend it.
Like if you log in via a browser?
Yeah, yeah.
Okay, I've logged in via like the browser, not the app, through the VA's
Yeah. Okay.
login.
Yeah. Yeah. So it's both. The website is the same as the app. It's just sometimes it's easier when you're with a patient. You can grab it. It's, you know, we're getting better at putting this in HealthLink, but it's still kind of a mess. And so it generally it's easier to find stuff on their portal. And
Yeah, it's
hopefully
mostly used to
someday
like
we'll.
search patients and
Yeah.
stuff like that, and I thought it was really helpful.
Yeah. Yeah. Thanks. Yeah. So yeah, if anyone's interested, yeah, email me and I'll get you set up. Yeah. Yeah. As Eric points out, it will be in HealthLink. The 2.0 and the oncology care redesign is taking all of IT's time right now. And so we're hoping by the end of the year that Tempus information is incorporated into HealthLink and it'll be more searchable and easier to find. Um, the portal will still have some search features that HealthLink won't have, so might end up using both tools anyway, but hopefully, like Strata before, we'll have it in HealthLink soon. Okay, on to antimetabolites. First used in 1947, the first metastatic cancer cure in 1956, which was ALL. Very exciting. 16 drugs here. As you can see, like here, kind of similar. Like there's, again, almost exact same in the 18,000 range for doses per year. A little bit less patients, so 1,500 instead of 1,800, and then a little bit less treatment plans, 268 instead of 350. But the medicines that are commonly used are used in all the big disease states. So gemcitabine, 5-FU, capecitabine, fludarabine, and then methotrexate. So sarcomas, GYN, GI, GU, these are used really in all diseases. This is a busy table, but essentially these drugs there's 4 different subclasses, and they essentially either inhibit an enzyme or mimic a DNA or RNA structure to trick the system into inhibiting synthesis. And then finally, there's azacitidine and decitabine that are quite a bit different in that they change DNA epigenetically. So they alter the gene expression, include like usually re-express things. So they upregulate tumor suppression genes and cell differentiation genes. Um, so essentially 3 different ways that these drugs work, even though this is a big table. Same thing here. So systems-based review, between 4 and 10 is neurotoxicity, hepatotoxicity, GI toxicity, a lot of black box warnings there. And then methotrexate, the first drug there, has a record for the most black box warnings. It has 15 total black box warnings, highest of any drug there is. Myelosuppression, again, all 12 of these drugs have myelosuppression as either a warning or a black box. Infection, hypersensitivity, again. Secondary cancer, again. Tumor lysis syndrome was in the previous one. Experienced provider was also in the last. Like an alkylating agent. So these alkylating agents and antimetabolites commonly used together, and they also have a kind of the side effect profile is there's some similarities. I'll do quite a few slides on methotrexate just because it's universally fatal if given inappropriately. And it's a good example of a system that we put in place where the whole medical team's involved, nurses, pharmacists, nutrition, doctors, to make sure that it's given safely. So it works in 2 different ways. It inhibits an enzyme, or 2 enzymes, and then it reduced like precursor folates are lowered, and then also purine and thymidolic acids are decreased. Dosing, we have a high dose methotrexate guideline. So high doses are greater than 500 milligrams per meter squared. This is also used in non-oncology. So you will be on heme consults and see, a room patient on methotrexate that has myelosuppression. And so we're seeing more and more adverse effects in non-oncology indications. So this delayed methotrexate clearance happens with baseline renal dysfunction with third spacing. So every time you want to kind of assess and even get an x-ray if you have to for somebody that might have pleural effusion, might have ascites, severe edema, liver dysfunction, hypoalbuminemia, dehydration, morbid obesity, and age. These are our patients here. So we found that AKI incidence, the highest was 35% if their BSA was greater than or equal to 4, and they were greater than or equal to 70. So kind of dramatic. And you can kind of see, I think the age incidence peaks out at 60 to 69 because generally those patients are a little bit less healthier. People that make it to 70 that can still get high dose methotrexate are in a little bit better shape, essentially. So that's why there's a little dip there. There's drug interactions. So we displace methotrexate from protein binding sites. We reduce renal tubular transport. We compete for P-glycoprotein, P450 metabolism, and renal excretion. And then proton pump inhibitors. So we do not give pantoprazole with high-dose methotrexate. It will delay clearance. We still don't know why that is. You can see with this drug, there's a lot going on. So here's our platform that we've built with nurses and pharmacy and physicians. So essentially you get 4 hours of pre-hydration, or sorry, before you're even admitted, we have sodium bicarbonate, which is baking soda and water. And then we have 4 hours of hydration. We're checking your NPHs frequently. And then we're checking methotrexate levels and serum creatinines at 24 hours after the dose, and then daily in the morning, unless there's problems. And then we are adjusting the supportive care as needed. So the supportive care adjustments are based on this. This is also something to kind of favorite, especially if you're on a heme rotation, I guess. Yeah, so we really have to give it IV if the dose is greater than 25, otherwise it's not absorbed. Leucovorin does not increase methotrexate clearance. It just it just provides the building blocks of DNA. So you're replacing what methotrexate takes away, not clearing methotrexate. Glucarpidase is available. We've used it 6 times in the last 5 years. It's not a super commonly used drug. Essentially, it's an enzyme that takes folic acid, um, both folic acid and methotrexate, it breaks down. And so after that, you have to replace the folic acid because you've destroyed it all. Um, the doses are there. We have certain requirements to meet, mainly like the methotrexate level is used. So if it's greater than 50 at 24 hours, we really think about using this. And then there is a separate, like the test that looks at methotrexate is falsely high after glucarpidase because it picks up breakdown products. And so no matter what, for 48 hours, we continue leucovorin and just watch the serum creatinine because the methotrexate level is not accurate. Okay, so for antifolates, methotrexate. So pemetrexed would be used in gyne and lung indications. Important to note here, you do daily folic acid for 7 days, vitamin B, and then dexamethasone pre-meds are a little bit different. So kind of this is not an inpatient drug, and we still worry about myelosuppression and GI tox, but that's how we prevent it for this drug. Moving on to purine analogs, 6-MP metabolism. So xanthine oxidase is inhibited by L-epinol, and we prefer to not give 6-mercaptopurine with L-epinol. For most regimens, this will not be given cycle 1, so hopefully you're out of the tumor lysis weeds and don't need L-epinol. But this is the mechanism for why it's a problem. TPMT in European and African Americans, 10% of patients will have a heterozygous deficiency, which means they get 30 to 80% of the normal dose. And if they don't, they have major increase in myelosuppression, major increase in risk of secondary cancer. And then we'll have 1 in 400 patients that's a homozygous deficiency. For those patients, we have to reduce by tenfold. So they'll usually get a dose on Monday, Wednesday, and Friday, and that's it. So just we check TPMT for this drug for all patients and dose adjust appropriately. New 15 mutations are more common in East Asian patients, and so very important to check that mutation. Up to 20% of patients can have a heterozygous deficiency. The other two purine analogs, clodribine is for some of our regimens given sub-Q. This was approved sub-Q in Europe, and they have a more concentrated drug product. And so dosing there is more like azacitidine, 3 to 4 injections. But here in the US, we still have the lower concentration product. So it can be, just to note, it can be up to 7 injections per patients. They don't love that if they don't kind of know about that. We can give it IV if needed, but just important to note. Fludarabine, we often will like give seizure prophylaxis, but at the same time, the doses we use are generally much lower than those found with the seizure inducing doses. T cells are depleted, so infections are much more common in fludarabine. And then we have to be really careful because the primary metabolite, which is increased in renal impairment. So we'll generally reduce the dose 20% in patients with renal impairment because of this. Pyrimidine, so both 5-FU and capecitabine, hand-foot syndrome will show up. These drugs, again, are used, there's thousands of doses a year given. So this is a common adverse effect that we'll see. Ibuprofen helps the most as far as pain meds go. It helps more than opioids or Tylenol. And then udder cream, really being like using moisture cream as much as you can, and before the symptom comes on. Avoid like things like chain sign, like playing tennis, like repetitive kind of motions with your surfaces should be avoided during this time. Mucositis also is an issue, and so for both melphalan and 5-FU patients, if they get a bolus, not if the bolus is not given, we don't do this, but ice chips for 30 minutes. And then just a lot of general good oral care, like brushing your teeth, like doing normal saline rinses, occasionally using a Dexapine mouthwash is helpful. Sucralfate has been shown to not be helpful. Another pharmacogenomic piece of information, and so the DPYD enzyme activity. We're getting this more and more with patients up front, but we don't get it for everyone. There's a partial deficiency in 3 to 6% of people. And in these patients, essentially the active metabolite is not metabolized. And so severe toxicity can develop. That's cytopenias, mucositis, and diarrhea, which diarrhea is generally the most pronounced to the patient. Capecitabine has a really nice package insert dose adjustment table. I don't have this memorized, but we can, can kind of always go here and take a look. Infusional 5-FU and capecitabine generally have different side effect profile than bolus 5-FU. Bolus 5-FU is not always shown to be like add to effectiveness, so a lot of times it's omitted in our regimens now, FOLFOX. Occasionally we'll still do it, but it has to, you're kind of picking the patient based on can they tolerate this or not. We have had pump failures at home. It's usually not Chartwell. It's usually like other home infusion systems that fail. So we had 2 patients in the last 5 years that have had a delivery of the whole 46 hours of 5-FU in 30 minutes. And so if that happens, we have an antidote to give to treat this. So we basically get them admitted right away and assess their toxicity. This drug comes from Memphis, Tennessee. We have to order it. So let pharmacy know as soon as possible if this is needed. You can call us right away and we can start working on getting it ordered. And then it's every 6 hours for 20 doses as soon as we get it to prevent overdose. And we almost always give growth factors supportive care just to help with the myelosuppression. All right, so here is those tips essentially repeated. I guess for high dose cytarabine, we do steroid eye drops. That's because the cytarabine actually is excreted in tears. And so the steroid eye drops help prevent that inflammation. Gemcitabine, be very, very, very careful with prolongation of the infusion. So sometimes it'll be a little old lady with a peripheral line that's not working very well. And people think about slowing down the infusion to get through it. Would be a real problem. Like patients would have likely severe myelosuppression. So we did have a patient that was in her 70s and it went over 90 minutes and she had to be admitted for neutropenic fever and myelosuppression. Very careful to not do that. Then our last class of drugs here, azacitidine has several mechanisms of renal injury, but we're still not super well versed in what's going on. There is direct toxicity, there's acidosis. It can cause like excretion of certain chemicals, I guess, just bicarbonate, for instance. And so essentially you're watching renal function closely with this drug, and we have to consider dose reductions as needed. Azacitidine will be given for many, many cycles, 40, 50 cycles is not uncommon. So we want to rotate the sub-Q sites. IV drug is only good for 1 hour. Beyond use days is only 1 hour. So we try not to give that medication unless absolutely needed. And then I think this is the last slide, kind of going through renal hepatic dosing, pharmacogenomics, kind of showing again that it's kind of all over the board, and make sure to kind of look it up instead of assume it's a class effect. And that is it. Sorry for the rush in the last 10 minutes. Are there any questions at all, or thanks for the attention?
This has come up as a VA a couple times. If someone hasn't taken B12 and folate before pemetrexed, how does UW handle it?
Yeah, we um, we try to push off the dose, to be honest. Um, you can, like, I've seen people give a higher dose of folate, like 5 milligrams for 3 days, and the IV vitamin 12, of course, B12 acts quickly, but it's really we really do try to delay the dose 7 days if we can.
Okay, thanks.
Any other questions? These are oldies but goodies. Still like they'll still be